Good morning, I'm Susma Lamichani Thapa. Today I will be covering the pathophysiology and highlight some of the clinical manifestation of asthma. Do you know that Australia has the second highest prevalence of asthma in the world and are most common on children compared to adults? Acute asthma may be characterized as airway obstructive disease, persistent airway inflammatory disorder. As described by Costco, the immunohistopathological features of acute asthma that comprise invasion of inflammatory cells by way of demonstrated involvement of the neutrophils, eosinophils, lymphocytes, activation of mast cells, and epithelial cell injury. The key cause of acute asthma is inflammation of the airway that leads to the hyperresponsiveness of the airway, obstruction of the airflow, respiratory symptoms and chronicity of the disease in order to treat pathogens, excoriations, bronchoconstrictions or spasms, airway enema, hypertension, and remodeling of the airways are the main mechanism linked with acute asthma. In the case given below, the patient named Jackson Smith, 18 years old man who was admitted to the emergency department of the healthcare center at 9 p.m. with the diagnosis of severe breathlessness. The case evaluation and the family investigation confirmed that he had previously suffered from asthma and that he had an acute asthma diagnosis when he was 2 years old. In the scenario, the importance of assessing the clinical symptoms of the condition is necessary to diagnosis and to provide the condition with appropriate therapies. In this situation, it should be remembered that Jackson suffered from extreme dyspnea, 32 respiratory breath per minute, SpO2 is 94%, pulse rate is 130 beats per minute. In this situation, the medical examination has been effective in recognizing the extensive of reduced respiratory systems and widespread wheeze by chest X-ray. Explaining the pathophysiology associated with each pathological condition that Jackson suffered from in the first place, the presence of dyspnea or shortness of breath and difficult to complete sentence must be addressed. This should be the environmental stimuli or allergens that causes bronchoconstriction or tightening of patient airway with asthma and is usually induced by acute inflammation of the bronchial airways, which in turn interferes with the ability to breathe easily and decrease the supply of oxygen in the blood, thus contributes to shortness of breath. Remember that pulmonary airway inflammation has a close linking to asthma pathophysiology. Thus, this is the main pathogenesis that contributes to Jackson's extremely high respiratory rate, which is 30 breaths per minute, because the body tries to recompense for the lack of oxygen in the bloodstream that leads to a higher respiratory rate, which was the case with Jackson's. The narrowing and swallowing of the airway is the main source of advantageous respiratory sound and frequent wheezing in the patient. If the ear is caught in alveoli that rises the pressure of the alveoli is congestion the perfusion away. So it becomes very tough for the ear to get out, making a whistling tone as it passed out. The next set of clinical symptoms to be identified that needs to be addressed is 94% of SpO2. The most common clinical sign of acute asthma are hypoxia and hypoxemia, where oxygen is insufficient in the blood and tissue. The failure of the swollen and limited airways to supply adequate oxygen to the body that contributes to a drop in concentration also associated with hypoxia and hypoxemia. In the case of Jackson, his oxygen level is in the blood is 94% in room air, which is not that severe to be worried. But the other clinical manifestation he had been going through linked to each other, thus make it complication. In other words, during asthma symptoms, the smooth muscle gets constrict and dilate, and when it constricts, it narrows the limb, tightened, and the wall inflamed and thickened. That's why airflow distraction occurs, thus carbon dioxide is not moving out from the blood, so it stays in blood and decrease oxygen level in blood and increase carbon dioxide, which makes our blood acidosis. Eventually, addressing the high pulse rate pathogenesis at 130 beats per minute, high pulmonary load and high cardiac output are the collateral which links to each other. As stated by Wetherell, body's low oxygen concentration contributes to a strong cardiac load, injecting enough oxygen into the bloodstream to prevent the possibility of necrosis in cardiac asthma. Additionally, acute asthma is also related to pulmonary edema, which also adds to the cardiac load that result in extremely elevated heart rate. This is why the pulse rate of Jackson is strong and high. In the last clinical symptom, Jackson Smith chest X-ray shows hyperinflammation lungs because he was diagnosed with asthma when he was 2 years old, and when asthma attacks, Jackson had to struggle to breathe in and out due to narrow, smooth muscles. Thus, the patient had to use the necessary additional muscles and diaphragm effectiveness decreased due to overinflated lungs compressed. In fact, the lungs are hyperinflated by large mucus plugging in the segmental, subsegmental, and bronchioles and peripheral airways. Above all these signs and symptoms shows that he had a severe asthma and needs pharmacological treatment as well as 24 hours monitoring. By saying that, I would like to end my presentation. Hope you all enjoyed it and thank you for listening.